many as we can. We cannot bring all of them. Would even approach the witch doctors as well. They use it quite a lot. Welcome, Dr. Mutevi. So steroids are used by everybody. I think even God uses them. So let us invite the Dr. Namirembe Joy to come and take us through the case presentation. And we are going to be very quick. We have very limited time. Namirembe Joy is a senior health officer in the Department of Medicine. She's going to take us through the first case. You're welcome. You're not as short as me.
Thank you, Dr. Nakwagala. Good evening to you all. So this work was compiled by me and my colleagues, but in order to make it brief, I'll present everything. So I'm presenting WP, a 27-year-old male, single from Luzira. He's a Christian and is a mixed chapati by the roadside in Luzira. So he was admitted on the 10th of August and discharged on the 19th of August and was referred from Luzira Health Center for. His main presenting complaint was general body weakness for 2 weeks and pain on swallowing for 1 week. So this was a 27-year-old male with a history of self-medication of dexamethasone for over 6 years, and he didn't have any other non-chronic illness. And he presented with general body weakness that was progressive over 2 weeks, worsening during those 2 weeks. And I initially had exercise intolerance, but by the time he came for admission, he also had difficulty performing usual activities, such as climbing up the stairs and rising from a chair. So he reported a burning sensation in the lower limbs as well, associated with numbness. But however, he did not report any focal limb weakness. He didn't have any facial weakness, and he didn't report any loss of sensation, no history of seizures, and also no history of loss of consciousness. Neither did he have any blurry vision. In addition to this, he also had pain on swallowing, and this was to both liquids and solids, and was associated with low appetite. However, he didn't have any nausea, vomiting, abdominal pain, abdominal distension, constipation, heartburn, diarrhea, or hematochezia, and neither did he have any Mellina stools. He also didn't report any history of fever. In other systems, he reported progressive weight gain over the years, associated with reduced libido and reduced testicular size. He also reported heat intolerance, but not to the cold. And by the time of admission, he didn't report any polyuria, polyphagia, or polydipsia. Genitourinary system, he had a burning sensation while passing urine, and he noticed that in the past 3 days, his urine output had reduced. He didn't have any frequency, hesitancy, but he reported erectile dysfunction. As for the skin, he reported a wound on the left leg that started as a small pimple and increased in size, and he has had this wound for 1 month, wasn't healing. And there was no past discharge from the wound. So in the cardiovascular system, he didn't report any shortness of breath, there was no orthopnea, there was no paroxysmal nocturnal dyspnea, neither did he have any palpitations or lower limb swelling. In the respiratory system, there was no history of cough, difficulty in breathing, wheezing, or chest pain. In the musculoskeletal system, neither did he have any muscle pain, joint pains, joint swelling, or stiffness. So past medical history, this was the second admission. The initial admission was at Luzira Health Center, and where they did the random blood sugar noted you have hyperglycemia, upon which was referred from lack of further management. The reports he has been on and off dexamethasone. We don't know how much he was taking, and he has been taking this dexamethasone for over 6 years. He said he started taking it when he was prescribed the medication 6 years ago, when he had gone to see a clinician due to an itchy skin rash. But from then on, he had been self-prescribing whenever he felt weak. And he reported by the time of admission, he has last taken the dexamethasone 3 weeks ago. He reported no history of any other chronic illness, and there was no non-food or drug allergies. He reported to be HIV negative and had last tested in April 2026. There was no history of trauma, any major surgeries, or blood transfusion. So in family history, he's a father to one son, but he doesn't live with a mother. The son lives with a mother, and is the sixth child of 9 children where he comes from. There are 6 boys and 3 girls. He's a twin, and his twin sister died from tetanus. He didn't report any family history of diabetes or hypertension. In the social history, he lives alone in a rental in Uzida and sells chapati by the roadside. And he didn't report any history of alcohol use, and neither did he report any history of smoking tobacco. So in summary, I've presented a 27-year-old male with a 6-year history of chronic dexamethasone use, referred from Rosella Health Center with hyperglycemia, who presented for both liquids and solids. I reported weight gain over the years and also had a non-healing wound on the left leg, and also had a burning sensation in the lower limbs, heat intolerance, reduced libido, erectile dysfunction, and reduced testicular size. He's HIV negative, lives alone, and sells chapati by the roadside, and reports no history of alcohol or smoking tobacco. So in view of the history, we made an impression of iatrogenic Cushing syndrome due to chronic exogenous dexamethasone use. And this was complicated by steroid-induced diabetes mellitus with hyperglycemia. At this point from the history taking, we can't say if he has diabetic ketoacidosis or hyperglycemic hyperosmolar syndrome. Then because he presented with burning sensation in the lower limbs, he also probably has peripheral neuropathy. And because he has general body weakness that was progressive, he has difficulties climbing stairs, has difficulties standing up from the chair. We also thought he could have steroid-induced myopathy. And because he had monophagia for both liquids and solids, and it was acute, we were thinking he has an oropharyngeal candidiasis, which is very common in those who have reduced immunity due to chronic steroid use. And because of the chronic wound on the leg, concluded he has impaired wound healing. Then because he had a burning sensation when passing urine, we thought he could be having also urinary tract infection. From the differentials, we would think he could be having metabolic syndrome because he's having weight gain and he's having hyperglycemia. However, with metabolic syndrome, rarely do they present with reduced libido, reduced testicular size, and neither did he have any history of hypertension, and neither was it there in the family. Then this Cushing syndrome could be endogenous, and what is for however, because of the strong history of chronic dexamethasone use, it's more likely to be an exogenous cause than endogenous. Then because of the chronic steroid use, you could be having adrenal insufficiency following steroid withdrawal, because he had reported he had not taken that steroids for over 3 weeks. And this presents with what is in for it is general body weakness and the fact that he has stopped taking that dexamethasone for 3 weeks. However, he didn't present with other symptoms of adrenal insufficiency, such as nausea, vomiting, abdominal pain, dizziness, anything that could point to hypertension. And the fact that he came with hyperglycemia also makes it unlikely, because with adrenal insufficiency, they usually present with hypoglycemia. Then the other possibility could be hypothyroidism because of the progressive body weakness and weight gain. However, he had heat intolerance, making it unlikely. So on examination, the vitals, besides a respiratory rate of over 24 breaths per minute and the random blood sugar, which was high at 23.4 millimoles per liter, the other vitals were basically normal. And generally speaking, he was sick looking, He was a febrile, he didn't have any pallor, he didn't have jaundice, there was no edema or finger clubbing, no cyanosis or lymphadenopathy. However, he looked dehydrated with dry lips and he had an oral thrush. Then he also had the typical round swollen full face, the hormone face of Cushing syndrome, and also noted a dorsal cervical fat accumulation, which is known as the buffalo hump. His skin was thin and fragile, and we noted large violaceous striae on the upper arms, the abdomen, and the thighs. And then he had that clean ulcer on the left leg in the calf area, which was about 2 by 3 centimeters. It was well defined, the edges were clean, and he had a clean granulating base. There was no purulent discharge. The surrounding skin was not edematous, and it wasn't hot, and there was no swelling. I basically put these images for the undergrads to see what a moon face could look like, what a buffalo hump could look like, and to show you also that central obesity. You notice that he has a lot of fat around the abdomen. So central nervous system, he was alert, oriented, timeless, and person. His GCS was 15/15. His memory was intact, and he spoke fluently and coherent speech. He didn't have any cranial nerve deficits, and on motor exam, he had normal muscle bulk, tone, and power, and also there was no proximal muscle weakness. The sensation was intact, and also the reflexes were normal, as well as coordination. When it came to abdominal exam, it was distended, could say it was obese, and he had extensive violaceous striae over the abdomen, as you can see in the picture there. It moved with respiration. He didn't have any scars or any visible masses. It was soft and non-tender, and there were no palpable masses. And when it came to the genitals, besides the testes being slightly small, measuring by 3/2, but they are not tender, and there are no other abnormalities noted. For the respiratory system, besides him having a tachypnea of 24 breaths per minute, his SpO2 was normal, and his chest was symmetrical, didn't have any deformities. Percussion note was resonant, and on auscultation, he had bronchobreathular breath sounds bilaterally and didn't have any added sounds. For the cardiovascular system, the pulse rate was 98 regular, synchronous, normal volume, and the periphery was less than 3 seconds. The JVP was not traced, and the precordium was normal active, apex beat in the intercostal space. On auscultation, we had the normal heart sounds 1 and 2, and there were no murmurs. So from the examination, we didn't differ much from our prior impression. So a number of investigations were done, and as you can see from the full blood count, really there was, besides the low MCHC, the parameters were in normal ranges. Then when it came to the differential white cell count, it just had a slightly raised neutrophil percentage, but the absolute count was normal. The significant findings were in his urine, where he had a protein of 3 pluses, he had glucose, he had ketones, and also some blood. But there are no features of IUTI, so there are no nitrates, and also there are no past cells. His cholesterol, the total cholesterol was within the normal ranges, only the triglycerides were slightly raised at 2.4. Then for the liver function test and the renal function test, besides the GGT, which was slightly raised, the renal parameter, the LFTs were basically normal ranges, and only the creatinine was raised at 129, but the urea was normal. Our electrolytes were normal ranges. I would have loved to do a thyroid function test, but was not able to afford it since the Mulago lab was not able to do it. And also to rule out adrenal insufficiency to do the morning AM cortisol, couldn't afford to do it as well. So in view of those findings, we maintained a diagnosis of iatrogenic Cushing syndrome due to chronic exogenous dexamethasone use, complicated by steroid-induced diabetes mellitus with diabetes ketoacidosis, oral candidiasis, impaired wound healing, and a possible AKI because we didn't have any baseline renal function tests. So while on the ward, he was managed on IV fluids to manage the dehydration, giving insulin with the diabetic protocol, the DKA protocol of hourly insulin until the RBS is 14 millimoles per liter, and later on he was fixed on Mixtard at 20 and 10 IU pre-break and pre-supper. He was also given oral fluconazole for the candidiasis, and one of them random blood sugar, the urine output, and the vitals. We noted the random blood sugar was well controlled, and on discharge was less than 10 millimoles pre-breakfast. He left in a very good condition. For the wound, we gave him normal saline to keep cleaning the wound and applying pyrosin ointment. Then, because we're not sure if it was in adrenal insufficiency, we maintained the oral hydrocortisone to help with the possibility of the hypothalamic pituitary axis being affected. Thank you.
Thank you very much, Dr. Christine. I know that was well done. We can have 1 or 2 questions since we have 2 minutes to closure of your time, and then you address them and we move to the next presenter. Yes, please.
And then on the description of this argument, needed to know the process how disease come and what sorry from what was the progressive. And given that it was the fact that I really the diagnosis of the so fact that thank you so much.
Thank you so much. Those, I think, are 3 questions. We had said 2, but maybe one more person, if you have something, something you can't put to the next. Someone this side. Okay, the lady next. Okay, so by the time we finish this grand round, some of these things you'll have an idea what will happen to the patient, but Christine, you can come and address those few. You have only 1 minute. Thank you.
So about the skin itching, that was 6 years ago when he was induced on dexamethasone. Kept self-prescribing. Whenever he felt weak, he said whenever he take the dexamethasone, he felt strong. That's how he would self-prescribe. Okay, that's a possibility, but since we couldn't see what's in the esophagus, we couldn't say esophageal candidiasis. Thank you.
And the Buffalo Hub, maybe you will know along the way. So the case presentation time is up, but we can respond to maybe 1 or 2 questions online, and then we move to the next presenter. Thank you. Can you open them up?
So the questions online, someone asked, is the patient going to be considered for being taken off the anti-diabetic treatment since steroids can cause temporary features of diabetes mellitus? Then the other question is, the doctor said there were no baseline renal tests, but I saw creatinine was elevated. What does she mean by baseline tests? I think you just respond to those two and then we go to the next presentation.
So this patient will need to be followed up to decide as to whether we take him off the diabetic drugs or not. For the baseline renal test, I was talking about if it's an AKI or a CKD. What I meant that this was the first test we had done. We didn't have any previous labs. That is what I meant. Thank you.
Right. Thank you, Dr. J, for that presentation. Up next is Dr. Matevi Edrisa, who is going to take us through the epidemiology of this problem. Dr. Matevi Edrisa is an endocrinologist and an epidemiologist. He's a lecturer at the College of Health Sciences, Makerere University. And please join me as we welcome Dr. Matevi Edrisa.
So how long do I have? 10, 15? 15. So good afternoon, everyone. Professor Kaddu, you're very welcome. So this afternoon we are talking about steroids. Steroids are very complicated substances that virtually affect every part of the body. Actually, as we were discussing who are going to the presenters, we're thinking of cancer, we're thinking of HIV, we are thinking of, so it was going to take the whole week. So we said, fine, let us select a few so that we just tickle a few things here and there. So over the next 15 minutes, we're going to see the burden. Do we have a problem with steroids? What is there for us to worry about? So we are going to see a little bit into the history, and then I'll throw a little bit into the statistics, and then the extent of the problem that we have. You know, some of these discoveries, I'm looking forward when they will say that Dr. Mutebi or Dr. Nakwagara, Professor Kaddu. But as early as 1930, we had some great scientists, Edward Kendall and his colleague from Switzerland. They're the first people to extract cortisol from the adrenals. And somewhere along the way, another scientist actually found out that they can actually use those steroids in rheumatoid arthritis. I don't know how we discovered that as early as that. Somebody should dig the ethical components. Dr. Nakwagara probably will tell us whether there were some ethical issues there, because I believe by then the guidelines were not fully up and running. However, so all three got a Nobel Prize for their discoveries in physiology, stroke medicine. And you can imagine over the 10 years from 1950 to 1960, we hadn't discovered that these chemicals are actually good, but very dangerous to the body. So the guidelines, the starting guidelines were laid down in 1960, after 10 years of use of these drugs. So initially, they were being used for inflammatory conditions, but over time, they discovered they could be used in other conditions. So over the years, the different steroids kept on being discovered. Initially, they discovered cortisone, and as the years went by, they discovered hydrocortisone, they discovered prednisolone, and then all the other steroids up to dexamethasone, and many more as the years went by. Now, I'm sure Dr. Chimuli is going to take us through the details of what the steroids do in the body, how are they produced, what effect do we expect in terms of benefit, in terms of side effects. But as we are going to discuss the burden that we have with the steroids, it's important for us to realize that these steroids affect every part of the body. every part. So as a doctor, if you're prescribing a steroid, you have to mind that, okay, I'm using this steroid as an anti-inflammatory. It is going to affect my metabolism, my endocrine system. As I'm using them for anti-inflammatory within the GIT, it's going to affect my immune system and it's going to cause infections. As I'm using it for eye inflammation or eye conditions, it's going to lead to depression in the central nervous system. Okay, so one has to keep that in mind, that they're going to hit every other part of the organ and create either desired effects or undesired effects. And that's why cortisol is known as a life hormone. You can actually call it part of the family of the master hormones. You run into trouble with steroids, you're virtually going to have problems in every system of the body. So they have that cyclic effect that they're creating benefit in one organ, but they're creating a terrible effect in another system. So one has to keep that in mind, the cyclic effect of the steroids. So if we go into the statistics across the world, why the steroids, the use has been on the increase is, one majorly is because the market is growing. Steroids, the market is projected to go as high as 6.9 billion. Those are dollars. So that's why you see people all over the place are scrambling to increase, to get a share of that market. For your information, these steroids are used in poultry, they're used in veterinary medicine, they're used in what is that called, a piggery, they're used in the fish industry, and all those are part of the whole cascade of issues we have, because those find their way into the food chain and they get back into humans. So it's a big industry. So when you look at where people get all these steroids, the major source is usually hospitals. It is you and me who prescribe these medicines. However, just like the patient we saw that these patients continue taking these medicines even on their own, even after we have prescribed these drugs to them. So we have to do a good job in advising them how long they are going to take them, the different effects they are going to get, the dosing. So we have to. Okay, go ahead. So we have to find a way how we utilize the different platforms. But there is a big number, almost an equal number, they're getting their prescriptions from the pharmacies, they're getting them online. However, the drawing in purple is in the developed countries. In Africa, or even in Uganda, the sources are so many. These patients prescribe their medicines on their own, get them from friends, from herbalists, relatives, and even across the counter, the cosmetic shops, a huge source of these, especially the topical steroids. If we go into the skin, now globally, again, just to show you how big the market is. Now, when you go into the skin proper, now the market even becomes bigger. And it is because of that that we are running into trouble with the topical steroids. So this study was done in Kenya. We're going to look at a few studies just to show us how big the problem is. This study was done in Kenya, and they were looking at patients who were using topical steroids. And they discovered that majority of these patients who use the steroids were majorly ladies. Ladies were using more than the male, and most of them were getting them over the counter. Now that's very important. That means as we put in our efforts, we have to educate people beyond just the medical workers, because these people are getting them across the board or over the counter. And then you can see all the way, most of them were using them for a long time. They were using them frequently per day. And good enough, they're being educated. 93% had been given some knowledge about the steroids. Side effects were as high as 72% within that cohort in Kenya. And when they studied the side effects, the commonest side effect that they realized was lightening of the skin was a common side effect. Of course, followed by skin thinning and all the other side effects that my colleague Dr. Namtevi, I'm sure, will give us an insight into. Okongo in Mbarara did some work as well, looked at, went into the OPD, patients who were just coming into the OPD, looked into those who were using skin lightening creams vis-a-vis those who were not using skin lightening creams, but the rate of use of skin lightening creams was as high as 25%. Now that's big. That means 1 in every 4 was using skin lightening creams. And the factors, if you're a lady, again, it is more common in ladies, age between 31 to 45, and of course, somebody with a higher Rosenberg self-esteem score. Now that is a score that if somebody has a self-esteem, it scores your self-esteem. Now, those who have a higher self-esteem were more users of skin lightening creams. You know, when you're low, you are like, you give up. So when you're higher, you want to be higher. Okay, so 73% had side effects. That's a big number. And commonest, they had, striae, steroid-induced acne, dermatitis, skin alterations, and many others. The Bureau of Standards in Uganda. I tried to look for more studies in Uganda, but Dr. Namtevi, I think we're going to have to put in an effort. In Uganda, the studies were really hard to come by. But I found that UNBS had banned different skin substances that have got mercury or hydroquinone. I don't know if I went on the market, I wouldn't get any with those chemicals, but they were banned in the country. And of course, those with unlabeled corticosteroids are not supposed to be used by the general public. That is by the Bureau. So that means if you go out there, you have to be careful. As you're buying your lotion and whatever, you have to look, make sure there's no mercury, there's no hydroquinone. Okay, so this was a study looking at depression. Now we've gone into one sector, depression. And in this study, they looked at patients who are using steroids, vis-a-vis those who are not using steroids. And they monitored they looked at patients who were depressed and those who were not depressed. And then they looked for cortisol levels. They measured cortisol levels. They measured cardiovascular risk. They measured their blood sugar levels. They discovered that patients who were depressed had a higher level of cortisol. They had a higher level cardiovascular risk. They had higher sugars, and they had a lower HDL. Of course, in their study, it was very hard to tell whether, steroids can always cause depression or they can be a consequence of steroid use. But the message here is that patients who are depressed will certainly carry a higher cardiovascular risk. They'll carry higher levels of steroids. And then we'll go into critical care and cardiology. Here they assess patients who came in with cardiogenic shock, vis-a-vis those who were not in cardiogenic shock. So one group, they put them on steroids, and the other group did not get steroids. And anyone who can give us an interpretation for that? So the red ones are the ones who are using, are not using, red are not using steroids, and then the blue one are using steroids, and they're looking at mortality. Anyone? Where are my third years, postgraduates? Go ahead. The colors, the red one, we're not using steroids. And the blue ones, we're using steroids. So from this, unlike this is survival. If you see on the y-axis is survival probability. So the ones in red, we are not taking steroids, are higher in terms of survival. So their probability of survival is higher than the ones in blue who had a lower survival probability. Thank you very much. Okay. So their 90-day survival was 1.6 compared to those. So Haruna Mugirwa et al. Also did a study, looked in, went to footballers, baseball players, rugby players, basketball players, and almost 10% of these participants were using steroids in addition to other enhancers. Now that's also worrying. That means 1 in 10. Okay, so if you have a child who is playing rugby, you have to be cautious. Okay, and the sources were usually from either their colleagues or the coaching staff. Okay, another study, this was done in Denmark. They looked at 500 users of steroids, and then their cohort 5,000 control group. And they were looking at mortality. They followed them for a period of almost 7 years. Okay, again, our interpretation. Go ahead. Again, mortality, users versus non-users. So users had a higher mortality. Okay, so your users, they had, this time they had a higher, this is now mortality. The y-axis, the other one was survival, this is mortality. So the ones in red have a higher mortality. And since the two lines are not crossing, that means it is statistically significant. Okay, so mortality was almost 3 times among the users vis-a-vis their controls. And of course, they looked at many factors. They looked at side effects within those we are using. They looked at male infertility, testicular dysfunction, cancers, looked at thromboembolization, diseases of the liver. And if you look up close, you look at you see the hazard ratio column, you can see that almost all those factors were on the positive, meaning the users where the rates were far higher than the non-users in terms of all those different complications. Now, the worrying one was the cancers. Okay, so as you're using steroids, somewhere you have to keep in mind that it can actually trigger cancers. So as I end, it's very important for us to remember that diagram, that steroids are multi-organ. As you're treating one condition, keep in mind that you're going to have a good effect in one, but you're going to have predisposition to side effects in another. Thank you very much.
Thank you very much, Dr. Mtevi. So if you count 3 people from yourself, is their skin natural? Are they Coca-Cola? Anyway, for the ladies, please, you know they have said the prevalence was high amongst us. Embrace your skins so that you'll not end up with a worse mortality when you're unwell and all those other effects that you've seen. Anyway, we have some questions, I'm sure. And when you get home, check the cream you're using. Yeah, because they're on the market. They have all sorts of steroids. They'll give you a smooth skin, but at the end of the day, your adrenals are going down. For the men, by the time you get a wife, you're going to seek juju. So please, anyway, so can we have questions? I know we have some questions online, but we can entertain 2 questions from in here. Do we have any footballers and rugby players in here who are using the anabolic steroids and you want to ask something? Okay, Dr. Nakwagala needs, maybe he's going to tell us something. I know it's not a question, but you're the expert in this. Yes, which is good. Can we take up more so that you stand at once? Okay, thank you very much, Dr. Nakwagala. If he stands, he will sit once and for all. So if you have a question, put it up. Yes, please. With what? Shock. Okay, thank you very much. Yes, Prof. Only men are asking, are we guilty, the ladies?
Thank you, Doctor. I think the other area mostly yes. I don't have the figures of the data. I'm writing important so they the faster injection of antibiotics.
All right. Okay, thank you so much, Dr. Mtemi. You're welcome to respond to those questions.
You're very welcome, our head of department, Professor Mayer. You're very welcome to this gathering. We are always privileged when you're around because we always remember excellence, integrity, and what? And discipline. You have to die. You have to make sure you die. Discipline, integrity, and excellency. So, data on use of steroids in the different sectors, the herbalists, vet, piggery. Surely, I tried looking around for the data. It is really scarce. But I guess since we have our postgraduates, somebody could maybe test the water and see if we have those steroids in our drinking water. But hope we don't run into issues with the national water. Okay, but somebody could go on the market and do an evaluation. But otherwise, if you go on the web, you can't get that data. But there is certainly an increase of use of steroids within those different sectors. Then somebody asked about shock. Okay, so the shock was cardiogenic shock. Okay, I'm not an expert in cardiology, but I doubt whether steroids are part of the first-line protocols within cardiogenic shock. So this was particularly cardiogenic shock. Yes. And actually, they found out that patients who were taking steroids in that category had a higher mortality than those who did not receive steroids. Then I think, Professor Mayer, you did some work on steroids in sepsis. Somebody is asking about steroid use in sepsis. I think you did some work in that area. So were steroids beneficial for them?
There was that data wasn't. It's very rare.
Okay. Okay. But in infection, do we give steroids? Is it routinely that we can give steroids in sepsis? Okay. 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 Usually steroids are very thin in terms of their therapeutic benefit. Like in sepsis, you want to start them early, but now you're also keeping your mind that you don't want to overdrop your immune system. You have so many other things that could be affected by these steroids, but certainly a patient who has got adrenal insufficiency, hypocortisolism secondary to infection, certainly would benefit. Thank you very much.
Thank you very much, Dr. Mutebi. And we welcome you, Dr. Chimuli Ivan, for the next presentation. He's a senior physician. He has taught many of us. So please welcome with me, Dr. Chimuli, to take us to our next question.
Thank you very much, Angela. You know, these things of introduction are very difficult. I prefer to come on as Ivan Chimuli, because I know that is how I came. So, good afternoon, ladies and gentlemen. I hope everyone is okay in their place. I was requested to prepare a 10-minute presentation, and I hope that I'll not take too long. Keep to the 10 minutes that I have been requested to do. So I only have two objectives. One of the objectives is to tell you about the hypothalamus pituitary axis, and it is not really telling you new things, but reminding ourselves, and then hopefully this chronic exposure to steroids, how it disrupts the signaling and suppresses the axis. So if you ask me, glucocorticoids primarily, we have cortisol. These are essential hormones. And these hormones are released in small amounts, as you can imagine. But they are very important in homeostasis. The internal environment of a cell has to be kept within narrow ranges of different biochemical elements. For those of you that are conversant with endocrinology, you know that hormones, some of them act where they are produced, and others act away from where they are produced. Glucocorticoids have this particular element that more of the glucocorticoids are produced in the hypothalamus, okay? And they work in where the stimulant is from the hypothalamus all the way down to the adrenal cortex, but then they work in very many places. And it's simply because they are steroid hormones. So they can fix themselves in any membrane, and then they enter into the cytoplasm. Their receptors are in the nucleus, and they affect a lot of gene-making receptors. So that is how come they have a wide effect. So their effects naturally are not meant to be harmful. They're actually supposed to be very protective. But toxicity usually arises when we have excess, when we have prolonged use, or when we have a physiological, an element of being physiologically inappropriate. So in terms of production, these hormones follow either a circadian rhythm, something that is predictable over a 24-hour period, or they could actually have an ultradian or a pulsatile rhythm where you produce it when you need it. Right now, you could have a small bump in the amount of cortisol simply because of something that could just without knowing inadvertently stress you. So they also respond to acute stress. You have seen this. You need it when there's an exam. If right now I came and I said we have an exam following this, by the way, I should have put an exam from medical students after this grand round, so that, you know, we do progressive assessment. So this would be a good progressive. But if I just told you right now that there is a test after this grand round, I can guarantee you your cortisol, most of you, your cortisol would do what? You'd be in a spot of bother. You'd be like, surely, why? But this is something that is important for survival. And they are controlled by a negative feedback mechanism. So normal tissues usually experience glucocorticoid signaling that is going to vary in magnitude, timing, and duration. And like I said, this is very important for survival. However, when we introduce exogenous glucocorticoids, that is usually where problems start. So these are known to all of us, the physiological effects of glucocorticoids. They are multi-system hormones. So they play a role in metabolic processes, they play a role in the immune and inflammatory function, cardiovascular, CNS, and behavioral. You will learn that the bone requires cortisol for the bone to develop, and when you don't have cortisol, you will have bone malformations. You, in a way, if you don't have cortisol in its right amounts, then you're in trouble. So within normal limits, this is what is supposed to be. But when we go beyond normal limits, when we disrupt the normal rhythm of production, and this normal rhythm of production comes in with the normal pulsatile or circadian values or levels that we have in the body, which run the hypothalamus pituitary adrenal axis normally. Once we have an excess of these glucocorticoids and we eliminate the negative feedback mechanism that is supposed to keep the axis running, then we kill the axis. And once we kill the axis, because we have introduced exogenous hormone, the exogenous hormone does not have a negative feedback mechanism onto the paraventricular cells in the hypothalamus. No, it doesn't. And that is where the problems start. In a normal setting, the cortisol that is produced naturally from the adrenal glands is able to exert a feedback mechanism, a negative feedback mechanism onto the pituitary gland as well as the hypothalamus. But when you take in the glucocorticoids that are exogenous, this mechanism is lost. But because you have enough cortisol running in the body, because of the exogenous cortisol, the body will think that you actually have enough. So what is it going to do? It is going to reduce the production of corticotrophin, which comes from the hypothalamus to go to the anterior pituitary. And with that, we are going to reduce what subsequently is going to come from what? What is going to subsequently come from the adrenal cortex. So when we have a reduction in or when we don't have feedback from the cortisol that is running in the body, and we suppress the axis, it means that your body is going to run on the exogenous steroid that you're putting in all the time. And when you stop taking this exogenous steroid, which we have said is important for many things, driving your glucose, driving your appetite, driving your state of elation, then you're going to continuously rely on this exogenous supply of the cortisol or the or of the glucocorticoid. So at appropriate doses, these glucocorticoids are important because they are going to suppress the inflammation. You know very well that when we do have glucocorticoids, there are two mechanisms in which they actually operate. They go intracellular, they get into the glucocorticoid receptor, and they either do transactivation or they actually do repression. So the repression is usually for the inflammatory pathway. By interacting with the NFK beta and AP1, they reduce the cytokines or the inflammatory response of the body. And in so doing, that's why people that have autoimmune conditions actually benefit from these steroids. So you reduce the inflammation or the inflammatory pathway, and therefore the symptoms that come because of excessive inflammation can actually be reduced. So that's why we use them in asthma, we use them in patients with rheumatoid arthritis. All these autoimmune conditions benefit. But also, we do have the other side where there's transactivation. So the transactivation mainly looks at the metabolic part. We have increased gluconeogenesis that comes in the liver. Because we want, the steroids are basically making you ready to sustain the body. They make and the energy of the body is glucose. So they make sure that your glucose levels are actually high all the time. At the same time, unfortunately, they also increase resistance to glucose utilization in the periphery. So the muscles don't take up glucose, okay? They increase insulin resistance, despite the fact you're going to be producing a lot of insulin. The patient in question that we're talking about today is a patient that had diabetes, right? And we think that this is a possible reason that the patient developed diabetes, iatrogenic diabetes mellitus, because of the exogenous steroid. So you have excessive breakdown of tissue and you're generating lots of sugar, but at the same time, you're not utilizing this sugar because the insulin is not working peripherally. At the same time, there's resistance, and this creates a position where only sugars can go high. There is modulation of the immune response that I've already highlighted. In terms of the cardiovascular system, when you have excessive glucocorticoids, it can also have a sidetrack of the mineralocorticoid activity, where the mineralocorticoids are responsible for sodium and water retention. So when you have excessive, oh, that's not mine. I thought I was the only one with an iPhone in the room. Joking. So, so the mineralocorticoid effect, once turned on, it's also going to give you lots of water and sodium retention. And so you are going to end up with a large vascular volume, but it's not because of anything, but it's simply because you're retaining water and sodium and possibly losing potassium. So the regulation of metabolism, talked about influencing glucose, protein. This particular glucocorticoid excess is going to force the body into breaking down protein. So these are the guys that are going to go into losing muscle. And once you lose the muscle, you form amino acids, and the amino acids are channeled into gluconeogenesis, so increasing more and more sugar in the blood. So these are, in a nutshell, what we are talking about: chronic exogenous glucocorticoid exposure, taking away the negative feedback on the axis, and then you have reduced corticotrophin releasing hormone, or rather corticotrophin hormone. ACTH is reduced. Adrenal cortex goes into atrophy because it's not producing anything. And then you have reduction in what comes from the adrenal gland. So a reduction in the endogenous cortisol. So when you're in such a situation, you are reliant on what is coming in from the exogenous source. So such a patient, just like this particular patient, you do not want to withdraw that steroid immediately because you have lost the natural pattern of the hypothalamus responding to what you have, because this cortisol is not activating the hypothalamus. So abrupt withdrawal is going to likely cause what you'd struggle with. I think Dr. Christine talked about it, that they continued giving the patient some, did you give Dexa? Was it Dexa? Hydrocortisone. They continued giving the patient dexamethasone because if you withdraw it, then you have nothing that is going to drive the other activities that we are talking about. So the patient stays empty. It's like a car that you have left in free fall, okay? So if you leave it in free fall, it's going to fall down and crack into very many particles. So in a way, in order for you to run away from the risk of adrenal crisis, you actually give something. And even in normal settings, when we're managing patients, these patients that we manage for something that is inflammatory, we don't take away the steroids abruptly. We taper down the dosing, because every time, even a single dose of a steroid actually has an impact on the HPA. So never be deceived that I only took 40 milligrams of PRED and that was it. Even a single dose, because when we do give the exogenous steroids, we give them in way, way higher doses than what the body actually produces, what is meant to be for normal homeostasis. So if you're, okay, I think that was my second last slide. Okay, so these are some of the complications that are going to occur because of the excess or continued use of exogenous steroids. Thank you very much.
Thank you very much, Dr. Chimuli. I feel like this was the actual, the real lecture. Yes, yes. Does anyone have a question? Yes, in the chat, I know there are some questions, but amongst us here, I'm sure you have questions, but you're wondering, how do I even put it up? Yeah. So, oh, Prof. Mayor, you're welcome. Thank you.
I think I want to comment. This thought was I know it's such a part of but I think what you're saying is in terms of how hard as well as the absence of a call or the use of shortness.
Okay, thank you very much, Prof. We have some more so that you respond at once. Yes, please.
Thank you, Dr. My question is that really formulation I agree. Yeah, for example, I think it's so important.
Okay, so we have a comment on the short course steroid therapies and his. We also have 2 questions online. Someone is saying steroids in asthma and COPD, inhaled steroids, inhaled form of steroids, and then systemic steroids indicated in acute exacerbations for 3 to 5 days is not long therapy. The side effects are described here. Okay, I don't see that question. I think this is a comment from Dr. Rejani. You can come and flash it so that people can read it for themselves. Then they're also asking that our patient had a chronic ulcer, which is due to chronic inflammation attributed to chronic steroid use. I think this one is confused a bit, yeah. But how come then this chronic steroid use, rather than suppressing the chronic inflammation of the ulcer and enhance healing, did not prevent healing of the wound? It's a bit jumbled, but the patient we presented had an ulcer, and someone is wondering if steroids can suppress the immunity. Why didn't they suppress that ulcer and heal it? Yes, so I see the specialists are smiling. I don't know if that means well, or Dr. Chimuli, you're welcome.
Yes.
The good thing is that we have a dermatologist coming for the next session. So she will tell us why this ulcer did not heal, despite the fact that we gave steroids. But we all know that a healing is a balance. You don't need to have excess of everything. For those of you that have studied in surgery, Professor Chijambu used to take us through wound healing, the process of wound healing. I don't know if you remember the entire process of wound healing. What is required for wound healing? How much of this comes from the effect of steroids? Steroids largely are going to be affected or rather they are going to affect the production of some cytokines. Are those cytokines important in wound healing? Maybe doctor will tell us. For me, I will not tell you that honestly. For what we know is that actually steroids are immunosuppressant. And when you're immunosuppressed, you reduce on your level of defending yourself against an attacker, in a nutshell. And a wound requires quite a number of elements that are supposed to come in and work together so that the wound actually gets better. But here you are giving it a steroid over time. Clearly, you are unlikely to have this wound heal. That is just English, okay? It is not science. Yes, Prof has asked about the short-term use. So there are times the immune system is actually overwhelmed, and we have had to use high doses of some of the inflammatory or of the steroids that we have given to patients. When you have your immunity out of line, you really want to suppress it completely. I think you've heard of pulsed steroids. You've heard of us using IVIG. You've heard us using some drugs that we use in cancer to really suppress the immunity of an individual for you to be able to sustain this person's life. Otherwise, if you do not sit on that inflammation, you are actually going to lose this person. So if it is a short-term exposure, sometimes it's even a single dose, okay? Sometimes it's just 5 days of exposure. You are going to relieve, and there's nothing like that this is not helpful. It's actually helpful in some circumstances. However, if it is short-term, the person that is prescribing it needs to be aware of which patients to give high-dose short-term steroids. High-dose short-term steroids. Most of the time, when we are giving short-term, and somebody was asking about what short-term means, most of the times when we talk about short-term, majority of the clinicians have been deploying 5 days of a steroid, of an exposure to a steroid. And this is because, and there's no black or white, this is because most of the times when you give a patient a steroid for longer than 5 to 7 days, you significantly impact on the HPA, on the hypothalamus pituitary axis. So for you to avoid putting this completely at, putting it to sleep, you want to start reducing your exposure of the steroid after 5 days. However, for people that have chronic inflammation, this may be unavoidable. So you have to have the balance between what is optimally useful for the patient to survive, but also what is not going to make the patient have their pituitary, hypothalamus pituitary axis completely suppressed. So it's a balance, and the literature is not going to tell you that when you do this, this is the perfect way of doing it. No, but it's just that there's lots of text. The literature is a little bit supportive in some places and not as supportive in other places. But we know that on average, it is a 5 to 7 day short course for the patients that we give the steroids. There was one more question which I might have missed. Or the one of IV oral. I think different drugs or different preparations have their effects initiated at the intracellular level differently. So depending on which dose you're using, we have equivalents that if you're giving something oral, we have so many milligrams of this that you should give, compared to if your intent is to get a certain effect. So it's a balance between what is going to give me this outcome, and probably what is going to give me this outcome faster. So you balance and you say, if the equivalent of the injectable for hydrocortisone is so much if somebody were to take an oral dexamethasone preparation. So it's nothing like this is better or the other, but as long as you are able to calculate and work out, and that literature, or rather the texts are available, that tells you how much is equivalent if you're using oral vis-a-vis injectable or parenteral.
Thank you very much, Dr. Chuki. We are going to have our next presenter, but there's something you didn't ask. Maybe you know. Why did the patient that Dr. Christine presented have testicular atrophy? Don't you think it came from these steroids? Maybe you know. Okay, find out. So we will come Dr. Namwitebi, who's going to take us through steroid use in dermatology. I know they usually start the patients on steroids, and when they see their skin clearing, the patient just gets to the next pharmacy and is always, using until they come to us. Dr. Namwitebi, welcome.
Good afternoon, ladies and gentlemen, in your respective capacities. My name is Fiona Namwitebi, and I have been tasked to talk about steroid use in dermatology and how to combat these side effects. So how do I go ahead? Okay, this is the roadmap for that day. I'll talk about the definition of corticosteroids. We shall also talk about systemic and topical corticosteroids. We shall have examples, indications of use, dosing, and adverse side effects. In there, we shall also talk about how to minimize these side effects. We shall also talk about how to screen for these comorbidities that may predispose us to these side effects. We shall also talk about how to monitor these comorbidities or steroid side effects. And then we shall conclude. So steroids, these are synthetic derivatives of the natural corticosteroid known as cortisol, produced by the adrenal gland. The route of administration for us is usually topical, but there are certain conditions where we do have to give it systemically and intralesional, depending on your diagnosis. So due to their anti-inflammatory, anti-proliferative, and immune suppressive effects, we have found that they are very useful in our skin conditions because most of them are allergies, most of them are inflammatory skin conditions or autoimmune skin disorders. And usually a dermatologist without a steroid is usually a dermatologist limited in practice. So we use them a lot, okay? So systemic corticosteroids we usually use, I will just highlight 3 in the interest of time, but orally we prefer prednisolone. Then IV, we prefer methylprednisolone. Intralesionally, we prefer triamcinolone. So this table is trying to show us how potent the different formulations are. We usually use hydrocortisone as a gold standard for comparison. So if I'm to take prednisolone that we usually use, so 1 tablet of 5 milligrams is equivalent to 20 milligrams of hydrocortisone. And for those who like dexamethasone, 0.75 milligrams of dexamethasone, if we compare it to our gold standard hydrocortisone, you will find that 0.75 milligrams is equivalent to 20 milligrams of hydrocortisone. So why is this important to know? If you look at the third column, it shows how potent these drugs are. So if you're going to give your dexamethasone, know that it's going to have 30 times more potency than a similar dose of hydrocortisone, an equivalent dose of hydrocortisone. So that means that we are going to potently or have rapid suppression of the HPA axis, meaning that the side effects will be more severe if we use dexamethasone than prednisolone. The onset of these side effects are usually faster, and their resolution is usually longer than the other steroids. You also note that dexamethasone is longer acting, more than 72 hours compared to the others. So for us, we rarely use it in order to combat these side effects. If we do use it, we usually do mini pulses. So now I will not task you to know all this, but I'm trying to illustrate the major indications of use of systemic glucocorticoids in dermatology. Number one is severe dermatitis, bullous disorders, vasculitis, autoimmune, connective tissue diseases, neutrophilic dermatosis, and others. I've highlighted those that we usually use, the conditions that we usually use systemic corticosteroids. Number one is allergic contact dermatitis. So your skin gets into contact with an allergen, you react. So we can give you some prednisolone. We also use it in autoimmune diseases of interest, the bullous group of disorders, the pemphigus group of disorders. Lupus erythematosus will be highlighted by Dr. Kaddu. Vasculitis is another area. We also use them a lot in people who have had radiation dermatitis, vitiligo, lichen planus. Some of you have been to the skin clinic and you've seen some of these things, and sarcoidosis. So most likely your patient you presented, doctor, was taking. Commonly we see people who come with Cushing's, with skin problems. They take dexamethasone because of atopic eczema or atopic dermatitis or psoriasis or urticaria. So in these conditions, we better avoid steroids orally, systemically, IV, or whatever systemic route you want to use, unless if it is specifically prescribed by a dermatologist. In rare cases, though. So I will not bother you much with this, doctor. The previous presenters have gone through the different side effects, but I have highlighted those side effects we see in the skin clinic due to systemic and topical corticosteroid use for a long time. So striae, we've seen the patient had striae, atrophy, ecchymosis, telangiectasias is usually visible blood vessels, infections, and some of you said, why don't the infections heal? Acne, topical corticosteroid withdrawal syndrome that is gaining much attention on social media. We have allergic sensitization, and sometimes it can mask dermatophyte infections. So for the systemic side effects, we also see HPA axis suppression, hyperglycemia, cataracts, and glaucoma. So with the HPA axis suppression, usually we see these people who use topical steroids for more than 3 months, even if it's of a low potency, they can have side effects. So what do we consider as short term? What do we consider as long term? So less than a month is short term. 1 to 3 months is intermediate use, and more than 3 months is long term, which results in most of these undesirable side effects. So for us, if we take it for a few days, usually 10 days, or less than 3 weeks if the patient has no comorbidities, we are usually okay. We think they are safe. Although in a small number of patients, they may develop HPA axis suppression. So how do we minimize? This is why I'm talking, this is what I was majorly tasked to talk about. How do we minimize these side effects? So if you, for example, take pemphigus vulgaris as a common disease that we usually manage with the internists. So we usually start high at 0.5 to 1 milligram per kg, usually anywhere between 40 to 60 milligrams. So this is taken as a single dose in the morning. So we give this high dose to gain control of the skin condition initially. For example, if it's a blistering skin disorder like pemphigus vulgaris or pemphigoid, we give it for 2 to 3 weeks. Once the last blister stops forming and we have had 80% of our skin starting to heal or re-epithelialize, then we start to reduce that dose by 10% to 20% of the initial prescribed dose. So what I will give you an example. If I start at 80 is more than 60. For that one, we shall even reduce at a higher percentage, usually reduced by 25%. So if I give 80 milligrams to gain control, that means I'm going to taper by 20 milligrams every 2 to 4 weeks. And then until I come down to 40 milligrams or 60 milligrams, then I go to, until I come down, yes, to 60 or 40 milligrams, and then I go down to 10 to 20% of the given dose. So an example, if I have reached 60 milligrams from 80, if I have reached 8 milligrams from 80, that means I'm going to taper by 5 to 10 milligrams every 2 to 4 weeks. So we also have to initiate other immune suppressant drugs like azathioprine or methotrexate at the same time in order to wean off the steroids early. So if you have other drugs you can use, for example, dupilumab for atopic dermatitis. We have TNF alpha inhibitors, anti-CD20 for SLE, and interleukin-6 inhibitors for vasculitis, or intravenous immunoglobulin for dermatomyositis and others. So low dose, we usually consider it's less than 10 milligrams per day, medium dose 10 to 20, and high dose more than 20. So we usually don't taper if the treatment is 3 weeks or less. So this is what we see as supraphysiologic doses of steroids. If it's more than 5 milligrams of prep, then that is supraphysiologic. But you see that we even give what we consider low dose is already supraphysiologic, so we have to monitor. So this mechanism of action has already been mentioned. This is how topical steroids also act. I will not go through it. And this table highlights the class of steroids. So we have very potent like clobetasol, potent like betamethasone valerate 0.1. Moderate, we have half-strength betamethasone valerate, and mild like hydrocortisone. So these side effects, to be controlled, you have to give the correct strength, the correct formulation for the site treated, and the shortest time possible to control that disease. So we usually find that ointments are not good for things, areas like the genitals, the flexures, and the face. So we usually use lotions that dry easily, gels or foams on the face. So the side effects that we commonly see in the skin clinic, we see worsening of acne, we see striae, and somebody asked if this is reversible. Yes, it is partially reversible. So most of the things we see are skin thinning, visible blood vessels underneath, And then we also have hypopigmentation, denting. If you wrongly give it to subcutaneous tissue, we have perioral dermatitis. Now on the left, that's where you see people putting MCG in the flexures. You have hypopigmentation and skin thinning, but this recovers within 2 to 3 months. So in order to apply this, to control the side effects, we have a fingertip measurement. So every part of the body has a number of fingertip units as measured at the end of the distal phalanx. So every area of the face you need, for example, will need 2.5, and 1 fingertip unit in an adult male is equal to 0.5 grams. So you will go through this later. And when you calculate according to the body surface area, 1 fingertip unit, which is equal to 0.5 grams, covers 2% of the body surface area in order to stop those side effects. So we need to pre-treat, to do pre-treatment screening. So if you're going to give more than 3 weeks and more, you have to check for diabetes, hypertension, infections, screen for H. pylori not to risk gastritis, and also you ask about interactions. If patients are taking other medications to prevent interactions, you screen for psychosis, glaucoma, and cataracts on history, physical exam, and laboratory testing. The similar approach applies to monitoring these side effects. So when you take your history, you examine and you think a certain system is affected, then you request that lab tests accordingly and initiate management and refer to the appropriate department. However, you must replace calcium and vitamin D for those who are deficient and advise them to take daily supplements. So for bone density scan, if you want to give more than 7.5 milligrams of prednisolone for more than 3 months daily, you must order I think that is Muju. There is a bone density scan, although it is expensive. So most of our patients cannot afford it. So that is the conclusion. We use the lowest dose of glucocorticoids for the shortest period needed to achieve control, assess for pre-existing comorbidities, and then initiate preventative measures and monitor them. Those are my references. Thank you.
Thank you very much, Dr. Namutebi. I know we have questions, but to cut down on time, let's have all the presenters first, and then we will ask at the end. And Dr. Namutebi is here. As you walk out, you can ask in case you don't get a chance to have your question answered here. So we are going to have the next presentation. And this is steroid use in rheumatology patients by Professor Kadu. Professor, you're welcome to take us through this section. Thank you. Keep your questions. If we get time at the end, we shall go through them.
Good afternoon. Actually, my work was already done, so I don't know why I'm here. So you have had the overview. I think Dr. Mutebi, Dr. Chimuri, Dr. Namutebi have given you the overview. But in rheumatology, just to highlight a few things, steroids are our cornerstone in managing inflammatory disease conditions. And as in dermatology, it's part of our treatment. I think we use steroids more than anyone else. So we are with them, they are with us. But we know that long-term use, it doesn't work. We know that long-term use carries long-term risk factors, which are well known and they have been highlighted. We want to use the lowest effective dose for the shortest time duration if you are to use the steroid. As we use them, we need to think about the barriers to steroid use, which subsequently leads to toxicity. We have the difficult to treat patients or difficult to treat disease. We have flares, which happen when we try to taper, as the earlier presenters have highlighted. We have challenges with drugs. You've heard about the steroid-sparing drugs, which the earlier presenters have talked about. They are limited in our setting. We also know that there are some doctors who are very reluctant to discontinue steroids.